Dr.
Right. Thank you so much. I think my slides are up now. Thanks for that introduction, and thank you to the SIG for having me. I'm excited to talk about brief interventions for anxiety today, and thank you all for joining us. I'm gearing this talk towards behavioral health providers, but it's also very relevant for primary care providers and others who want to learn about this topic. I am a licensed clinical psychologist, and I've been working in the PCBH model for over 7 years now. So I've been accumulating a lot of knowledge in this area, and I'm happy to share that. I hope it'll be useful for trainees, people who are transitioning from specialty care to primary care, and others. So we're going to talk about examples of the kinds of interventions you can do, and then I'm also going to share with you a lot of different resources that you might be able to use to help in your practice. I have no disclosures, but I have to note that I'm a VA employee, and these are my views, not the government's views. I want to acknowledge my mentor, Dr. Jennifer Funderburk, and another collaborator, Dr. Risa Weisberg. We worked together on a paper similar to the topic of this webinar, and I'll direct you to that in case that could be a useful resource for you. And I also acknowledge the Center for Integrated Healthcare where I work. Here are our learning objectives today. We'll go through 6 different kinds of interventions that you could use in PCBH, the main techniques involved, and again, I'm excited to show you a lot of different practice tools that you can use to help in your practice. So here's a quick overview of where we'll go. We'll spend most of the time on the actual intervention pieces themselves and the things you can do. Before I dive into anxiety, I wanted to do a quick refresher on the PCBH model in case anyone is not familiar. So this is a population-based approach to care in which behavioral health providers like social workers, psychologists, marriage and family therapists, counselors are embedded directly into the primary care setting. And they work as consultants to the primary care team. They're considered part of the team, and the behavioral health services they provide are viewed as routine care. And in this model, because it is population-based, the care is time-limited, and you try to shoot for about 1 to 4 sessions, which are very brief, like 15 to 30 minutes. And the biggest takeaway of PCBH is that it's consistent with the culture and the goals of primary care. It's quite unique from the traditional specialty mental health model that most of us are trained in. So this theme will kind of guide how we need to practice in PCBH, and you'll see that throughout the talk. So why am I talking about anxiety? Well, various studies using structured clinical interviews have determined that the prevalence of anxiety disorders in primary care patients ranges from about 15 to 20%. And that's just actual disorders. We know that subthreshold anxiety is also quite common and could be more common than the disorders. So this is very common in the primary care population. And anxiety is actually second only to depression and the reasons why patients are referred to see us in PCBH. I will note that depression is extremely comorbid with anxiety, so about half of patients, primary care patients with anxiety also have comorbid major depression, so you need to take that into account when you're figuring out how to treat folks. And of course we know from our experience with patients how impairing and burdensome anxiety symptoms can be. Anxiety, unfortunately, is undertreated in primary care, and that's where we can come in as behavioral health providers. So thinking about the options of existing evidence-based treatment for anxiety, let's consider the limitations for whether or not we can use them in primary care. So of course there's many effective medications for anxiety, but there's also a lot of reasons why medications are not a good option for many patients. So of course, we know that a lot of people just aren't open to taking meds for whatever reason. There's also concern about side effects. Sometimes meds are not advised for certain populations, like maybe pregnant women or geriatric patients for various reasons. And of course, sometimes medication just is probably not warranted if the symptoms are mild or transient or clearly tied to situational stressors and things like that. So a lot of times, pharmacotherapy isn't a good fit for people. When we look at the existing psychotherapies for anxiety, we run into a big barrier in that most of the protocols out there are disorder specific. So we think of things like CBT for GAD or CBT for social anxiety, very disorder specific and tailored to a particular condition. But in the real world, in primary care, we know that our patients do not fit into nice little diagnostic boxes. They have high comorbidity. They might have, symptoms of a lot of different anxiety disorders or comorbid depression. They might have PTSD. They might have a lot of significant medical concerns, things that are getting in the way. And we know that a lot of people just have kind of anxiety, not otherwise specified, just kind of a mix of anxiety symptoms here and there. And what's the protocol for those folks? And I also mentioned the prevalence of subthreshold symptoms. Again, these protocols are for diagnostic level conditions. So a lot of the options that have been developed in specialty mental health aren't going to work. And part of that is also because of the format they were developed in. So, we don't have 12 to 20 weekly sessions of 50 to 90 minutes to deliver care to our patients in PCBH. We know that about 50% of patients seen in PCBH only have one session with the provider. So, we need to have very, very brief interventions that we can deliver. So basically, when we look at most of the things that are out there, we see that nothing fits. And then we're this little guy here with the square peg trying to fit it in a round hole, and it doesn't work. So we need to think about how we can adapt from evidence-based treatment, but make it fit the setting that we are working in. And when we think about this, there's a couple things to consider. So on the anxiety side, the good news is that these anxiety disorders, they share a lot in common in terms of their etiology, their symptoms, maintaining processes, etc. As you can see listed here, these are common threads in the anxiety disorders. So that means we can take a similar treatment approach across the different presentations. We don't need to do, completely different treatment for GAD versus panic or something. The specifics will differ, but the underlying principles and the mechanism of treatment is going to be the same. On the PCBH side, we need to keep in mind that this is population-based care. So we have very brief episodes of care, and our goals are different compared to specialty mental health. So our goal is not to treat to remission like we're used to coming out of, the traditional clinic. Our goal in primary care is to improve functioning, reduce symptoms. So there's going to be a much greater emphasis on education, activation, and engaging in the patient in their own care. And that's part of the primary care culture, which is a different thing. So this means that in the unique setting of PCBH, kind of need to keep in mind our two main goals, which are providing education and teaching coping skills. And this is going to have implications for the scope or the level of complexity of our brief interventions. Okay, so here are the interventions that I'm going to talk about today. These are evidence-based CBT intervention techniques that are helpful and can be used across a variety of anxious presentations. I do want to note that our focus is on DSM-5 anxiety conditions, so I'm focusing on like generalized anxiety, panic, your phobias, social anxiety, that type of thing, and I'm not really speaking directly to PTSD and OCD, given that their gold standard treatments are mostly still applied in specialty care. But the same kind of principles apply here. We focus on these particular techniques because they have strong empirical support and they are consistent with the self-management and skill-building approach that's emphasized in primary care and PCBH. And also these particular techniques are quite amenable to the brief format we need to use in primary care. And I'm going to be speaking more towards adult patients because that's my experience, but for those of you who work with children and adolescents, you can adapt these as appropriate for the developmental level of your patients. So what I'm going to talk about is based on reviews of the excellent literature as well as years of clinical experience from myself and my collaborators. All right, so psychoeducation, of course, is one of the most basic tools that we as providers have. And, obviously this involves just giving patients information about their symptoms so they can understand what's happening to them. The nice thing about this approach is that you can normalize, you can correct misperceptions, you can help increased knowledge to facilitate self-management, and this really sets you up nicely by providing a rationale for other interventions that you might be using. And a lot of patients have very low mental health literacy. They don't really know anything about anxiety, so a lot of times a little information can go a long way. And psychoeducation can be done in just a few minutes, 5 minutes, 10 minutes, 15 if you want to go crazy. There's a lot you could cover in that time. You want to touch on, obviously, the common symptoms of anxiety, and I would encourage using a brief self-report measure of anxiety to facilitate that discussion. You want to highlight the anxiety spiral, so the types of things that are captured in this figure 1 here, helping the patient to get a sense of all the different factors playing into their anxiety. You want to explain the relationship between thoughts, feelings, and behaviors so that they can understand connections there. It's great to give some basic prevalence info to normalize how common anxiety is. And often can be good to talk about the adaptive nature of anxiety and fear and how a little bit of it is actually useful and protects us. But sometimes when it gets to be out of control, that's when it starts to cause problems. And you can touch on the goals of treatment, approaches to treatment. So this kind of basic information doesn't take a long time to cover, but it helps set you up nicely and give the patient information that they need. I would strongly encourage you to use diagrams to help those who are more visual learners, and it really helps pull things together, and also to give handouts because the patient's not going to absorb most of what you say. You're going to throw a lot at them, and only a little bit will stick. So if you give them a handout, that can be reinforced at home. So you could, make a handout with this type of figure, or here's another figure that I like, which illustrates nicely the wide array of factors that could be contributing to their anxiety. And here is a list of resources. Again, the slides will be available after the talk, so you'll have access to this. And so the Center for Integrated Healthcare, where I work, has a host of handouts, and you can access them. I also pulled a bunch of other different kinds of handouts that I like, and the ADAA website has a lot of nice content, including videos that can be useful. So there's plenty of tools that can help you give the patient something to take home with them. All right, so now I'll talk about mindfulness and acceptance-based techniques. These have grown in popularity over the last 15 years or so, and they emphasize awareness, acceptance, and values. And the research shows that these are very effective in their original format, which is for specialty care, and now they're starting to be used in the primary care setting as well. And there's some clinical literature that is emerging. Patty Robinson, Kirk Stoffel, and those folks use this a lot, and they've published a couple of books, as you can see there, within this approach. So it's definitely gaining traction. And there's a lot of different approaches you can take in this vein. So one thing is just using mindfulness training to help the patient work on getting in the present moment. So, I just very simply explain to patients that, when it comes to anxiety, you're spending a lot of time in the future, and your life is actually now in the present, and we need to find a way to help you be here now. And so a basic mindfulness, breathing exercise or something like that can be a nice tool to illustrate that. So that's one simple way you could apply mindfulness. And diffusion, the concept of diffusion from acceptance and commitment therapy is also a nice tool to use sometimes to help patients get some space from their anxiety. So helping them to see that thoughts and feelings are not, facts or the absolute truth. And so one way to do this is just the simple naming convention of attaching the phrase, I'm having the thought that, before they acknowledge an anxious thought. So even those few little words there can help illustrate, this is just a thought. It's not reality. So something even that simple could be useful for some people. And a big piece of the mindfulness and acceptance strategy is to focus on values. So that's a big piece of what you might be able to help people do. And a lot of times their anxiety gets to be so bothersome that they stop pursuing their valued activities in their lives. So you can work on discussing the patient's agency and their ability to pursue their values despite having anxiety. So a lot of people just respond pretty well when you have a frank discussion about the fact that, you can have anxiety and still, do whatever. And the best way to illustrate this and help them see that it is in fact true is to discuss times from their past where they were able to push through distress or discomfort because something was important to them. So if you can pull for an example, like childbirth or just raising children in general, or some sort of race, or working late, working hard on a big project, or something that they had to do where it was really hard, they did it anyway because it was important, can help illustrate that, yes, even though sometimes I have this anxiety, I can still pursue my goals. So that's another way you can use this approach. In terms of eliciting values and kind of focusing the session on that, some people will be able to just tell you, if you ask them what matters most to you in their life, they'll be able to articulate their values. Others will not. They will need a list or a worksheet or something to help them sort through that, because a lot of people don't really reflect on their values. So I'll give you some links to some nice worksheets for that. But once you've identified the patient's values and you've talked a little bit about the types of activities that they're avoiding due to their anxiety, you can help them come up with just a few specific goals that would help move them towards the direction of their values. And obviously this is playing on the concepts underlying acceptance as well as exposure. But you can help the patient come up with a few things that if they did, they would be pursuing their values, and then try to troubleshoot potential barriers and help them come up with a coping strategy just in case it becomes difficult. And a nice way to track something like this is this bullseye concept, and I adapted this from Patty Robinson's book as well as Tobias Lundgren's work. But just a simple, visual picture of how they're doing with pursuing their values. You can put work, love, play, help on here. You can put whatever their priority values are, and as you go through session by session, they can mark where they are in the bullseye. That can be nice for visual learners and for you to have a measure of if any change is actually happening or not. So you can download bullseye like this from the free materials from Patty's book if you like that. So again, lots of different ways you could incorporate mindfulness and acceptance techniques into your work. Now I would like to talk about relaxation training. So there's been various meta-analyses and reviews showing that this is an empirically supported treatment for anxiety. The nice thing about it is it can be taught quickly. It can bring about immediate relief of somatic symptoms, which are quite bothersome for many people. The traditional protocols of relaxation training from back in the day call for a high number of sessions, but this can be easily adapted to the brief format for primary care. So if you're approaching this in primary care, first thing you want to do, I think, is introduce the concept of the physiological relaxation response, and you really need to take care to distinguish that from common lay interpretations of relaxing, because most people think, a low energy activity like watching TV is relaxing, but that's not what we mean in this particular case. We mean the opposite of the fight or flight response. So make sure they understand what you really mean by the word relaxation. If the patient's already is already familiar with some sort of relaxation exercise or doing something, then you can reinforce that and help them get back into that habit. But sometimes it's good to have them demonstrate what they do, especially if they're doing some sort of breathing technique, just to make sure that they're using the correct technique, because sometimes people kind of interpret what they need to be doing. So I try to check in on what they're actually doing. But if they don't have anything and you need to teach them a skill, I think the most effective way is to really teach this during the session. Otherwise, they'll be skeptical. They might think it's kooky, and they won't give it a try at home. But if you do it in the session, then they can really experience it and see the kind of relief that it could bring. So I would encourage you to just pick one skill and teach it, 3 to 4 5 minutes in the session, and have the patient rate their tension or relaxation level before and after to get some data on whether or not they perceive a change. It's important to address some common concerns for relaxation training. So you've got to emphasize that relaxation is a skill, just like playing an instrument. That analogy tends to help. Like, we don't come out of the womb knowing how to play Mozart's Fifth Symphony. We would have to practice to become an expert at it. Same thing with relaxation. It's not natural for most of us. We don't spend time doing it, so you need to practice it to get good at it. Help the patient figure out a schedule of when they can do regular practice and plan that out. Make sure you give them a written guide or some kind of audio aid, and I will give you a long list of options for that in just a moment. And then take a couple minutes just to problem solve any potential barriers, like figuring out where they're going to do this, or will it be quiet enough, or what if they get distracted or frustrated or whatever. And some people will be very skeptical of relaxation training, which is normal. I just normalize those concerns. I say, a lot of my patients, they look at me funny when I bring this up, or they think it's silly or kooky, but once they actually try it, they find that it works for them. So just normalize it and note that, other patients similar to them have had a lot of success with it. Sometimes it works if you propose trying it as an experiment, that sort of thing. Okay, in terms of the techniques that you could do, I think it's nice to provide the patient with a menu of options for choices on what you do. So what I normally do is explain, 2 or 3 of these techniques, and then the patient and I decide which makes the most sense for them. So, if somebody has a lot of pulmonary issues, don't pick deep breathing. Or if they have a lot of chronic pain or some injuries or something, don't pick PMR. Or if they're very visual and creative, maybe guided imagery is the best choice for them. Or if, 10 years ago at camp they did meditation, go that route. So just figure out with the patient what's the most appealing to them and let them have a choice that can be helpful. My tips for each of these techniques, they're pretty straightforward. I'm sure most of you are familiar with them, but for deep breathing, I think it's very useful to have yourself, as you demonstrate, as well as the patient, put one hand on the belly and one hand on the chest as you're breathing, so that you can illustrate that you want the hand on the belly to be moving in and out with the breath, and the hand on the chest to be stationary. That helps really convey the idea of diaphragmatic breathing and what's supposed to be happening. For mindfulness meditation, my advice there is to listen to other people's meditation exercises to get a sense of what kinds of things they say. I know for me it didn't come natural. I had to practice it and listen to get ideas of what I could say. Otherwise, I felt silly doing it, and then I found I was shying away from doing it. So just expose yourself to examples of it until you feel comfortable and you know what you would say. The main way that I do the mindfulness meditation is just like 5 minutes of directing the patient to notice the sensations of breathing. So the sensation of their chest and belly, their sensation of their belly filling up like a balloon and then deflating as they breathe out, that kind of thing. The feeling of the air on their nose as they breathe in and out. And then I take it around the body, like noticing the sensation of your back against the chair or your feet on the floor, that kind of thing. And just a basic 5 minutes of meditation can be very, very nice for people. For PMR, I would say that you want to do somewhere between like 4 and 6 muscle groups. You can't do the whole body. You can't do all 16 muscle groups or whatever the standard protocol is. But you can do, something like forehead, biceps, hands, quads, and feet to give them a sense of what it feels like. And you could do that in 5 minutes, and that would give them a sample of it. And then for guided imagery, my advice would be to let the patient help you pick the scenario they want. So I ask people what's your favorite place in the world, or the place where you feel really calm, or what's a setting that you have fond memories of? And then, they can tell you, oh, I love to be at the beach, or my grandpa had a farm, or, the forest or something like that. So you can kind of personalize it to them. And then the other piece is to be sure you reference all 5 senses there. A lot of people just focus on the visual, but make sure you're getting, taste and sound and touch and things like that to make it a more rich experience. So, you can do a 3 to 5 minute demonstration of one of these, and that can be very useful, and then the patient can practice at home. I encourage patients to do regular at-home practice as well as needed use, when they're feeling very anxious. And you really need to sell the rationale for the regular practice so that the patient will actually do it. And so I work with veterans, and the analogy I use is that, when you were training for the military, you did training and you did lots of training drills so that you were ready, and it was second nature when you needed to use it in the heat of battle. And so the same thing with relaxation. You need to practice when you're not super anxious and get good at the skill so that when you need it, you can use it. So try to convey that so they can be more successful with the relaxation training. You don't want them to go home and try to use the skill in their first panic attack and they never practice it, and then it doesn't work. Then they think it doesn't work. Okay, so this is a nice list of handouts for you for patients, and I also included a link to a module about relaxation training in a CBT manual if you want to refresh yourself there. So lots of different written instructions you can give to people. Also, there's a lot of apps that are available to help with this. The VA and the Department of Defense have developed a lot of things that are good, and other commercial apps out there. Of course, I would only tell someone to get a free app, and I would only tell them to use it if I tried it myself first and made sure it was in fact legit. But these are ones that I've looked at and that seem to be pretty good. So if someone is really into their phone, you could suggest an app. You could also give them these websites. These websites have a variety of audio files. They have the spoken instructions and the calming music. And I always tell my patients, when I personally am doing relaxation, I like to just listen to the voice and do what she tells me so I don't have to think about it. So I'm encouraging them to use the audio files and also normalizing the use of relaxation with that statement. So lots of different options there in terms of relaxation, but the key point is you really got to do it in session with them to make them a believer a lot of times. Okay, so cognitive work in PCBH. So, in traditional cognitive therapy, the patient is learning to identify and evaluate the accuracy of their thoughts and develop alternative thoughts. In specialty care, in your longer protocols, you're analyzing automatic thoughts, you're going through thought records and all these kinds of steps. And cognitive therapy is quite efficacious across the anxiety disorders, but it is delivered in much longer format than we have in primary care. But we can take pieces of it and use it in PCBH. So I would say the caveat that this is challenging to cover in a limited amount of time, and it's not going to be appropriate for all patients. So you have to consider who you're working with and determine if this makes sense to go down the cognitive route for somebody. You got to consider their presenting symptoms and whether or not they're psychologically minded and things like that, and deciding if you want to use cognitive interventions. But for some people, this is very appropriate and very helpful. Okay, so I would say that the number one intervention that you're going to do in PCBH in this arena is just a simple highlighting of the contribution of negative thoughts and cognitive distortions to the anxiety spiral. So just pointing out that our thoughts have a role in our anxiety and our experience of anxiety is very important. A lot of people don't even realize that because they're just not thinking about this the way that we are. So that very simple thing, just noting that our anxious thoughts can get us worked up, could be your intervention. Another little thing is just educating that thoughts are hypotheses. They're not facts. They're not reality. They're just things that come and go in our head. that can help a lot of people to know that, even though that's very simple. In PCBH, you might get into a couple of the cognitive distortions. So instead of trying to tell somebody about all 20 cognitive distortions or whatever, you might just focus on overestimating or catastrophizing, because those are kind of two of the biggest ones in anxiety. And sometimes certain patients, you'll really hear a lot of catastrophizing. If you're doing your functional assessment with them for 15 minutes about what's going on, you can hear the catastrophizing. So you can point that out and talk about that with them. One easy and kind of playful way to get cognitive work in there is just this idea of catching yourself with the anxious thoughts or making cognitive distortions and labeling it as your anxiety monster, or you could even, or as your anxiety, or even your anxiety monster. So when the person realizes that they're ruminating or they realize they're catastrophizing, just calling it out and being like, oh, there goes my anxiety again, that's just my anxiety monster. Something as simple as that could be a useful tool for some patients, just getting a handle on the fact that this is my anxious mind again, this is not reality. You can also encourage patients to challenge their thoughts, so explaining that it actually is possible to challenge your thoughts. You don't have to believe everything your mind tells you, and explaining how one might consider alternative explanations and evaluate the evidence for and against their thoughts. So I'll give you some examples of that in a minute. But I did want to say that you want to make sure that patients don't mistakenly think you're just telling them to think more positively or think happy thoughts or something like that. If you get into cognitive work, some people will hear, that's what they will hear, that you're telling them to think happy thoughts and that's their fault, that they're anxious. So you need to, walk the line there and make sure that your true message is coming across as intended. Some people will misinterpret what you mean. So just one caveat about that. Okay, so sometimes it can be helpful to just go over an example to illustrate the role of our thoughts in our anxiety. And this is, I just put this up here as one example of how we might interpret the same situation 3 different ways and how that would in turn result in 3 different types of feelings. In the best case scenario, you would use an example like this that's tied to that particular patient's experience. But in PCBH, if I only have 5 minutes to do this intervention, I might not have time to elicit that. So you might use a canned example like this or whatever you like to illustrate the role of thoughts in our anxiety. And this is a pretty straightforward example, but it helps to show how the way we think about something can color our feelings. So even showing somebody something like this could be useful. Okay. Another simple exercise is just having someone look at the evidence for and against the thought, the anxious thought. So, if my patient his wife has cancer and she's in treatment and he's catastrophizing that she's going to die, we might go through a simple exercise of cataloging the evidence for and against that thought. So you can see the example here. Then I would have the patient rate how much they believe the anxious thought before and after we do this. This could take 5 minutes to do, and this could help them really see, if you get this out on paper, they can recognize when they're using black and white thinking or catastrophizing or what have you. So a basic thought record or exercise like this is one way that you can use cognitive work in PCBH. And another example is something like this. I found this what if exercise, which is just helping patients to think about alternative thoughts. So, people focus on the negative, obviously, and they're overlooking benign or positive outcomes. So a simple worksheet or discussion like this can help illustrate, there's another side of the story that we need to think about and remind them not to let the anxiety drive what they're focusing on. So this is a pretty straightforward exercise that you could do relatively quickly, or you could have a patient do at home. And I wanted to give another example. of the cognitive restructuring. So this is a pie chart one that I found, and could be especially useful if someone has health anxiety, or if they're fearing a certain outcome of a situation or something. You can look at their distorted belief and then have them come up with all the other possible explanations or outcomes, and then you allocate it on the pie there. So it's a nice visual exercise that can help people put some things in perspective. So these are just, 3 different examples of a way we might pull a little piece of cognitive work and adapt it down to a bite size, that we can do in 5 or 10 minutes in PCBH. Here's some resources for you. Module 9 and 10 of this brief CBT manual are about cognitive restructuring if you want a little refresher or some examples. And then all of these other handouts here would be for patients, just handouts to help guide, doing a thought record or how to challenge negative thoughts, things like that. So I want to give you some tools for that, because I know cognitive work is challenging in a limited amount of time. And again, think small here. It's not going to be like 10 sessions of cognitive restructuring that you would do in specialty care. That's not going to fly in this setting. It might just be explaining that our thoughts affect our feelings. Like that literally might be the intervention that you do. So just adjust your expectations down to fit the PCBH model and what you can get accomplished in the brief amount of time you have with the patient. But a little can go a long way for a lot of people. Okay, next I want to talk about exposure, which is obviously the hallmark of CBT for anxiety. And we've all learned about exposure and how it works. It's perhaps the most effective intervention for anxiety, but it can be very tricky to pull off in the PCBH setting. But it can be done, so I wanted to discuss that a little bit today. Now, exposure is going to be challenging due to the time constraints, because you have a limited number of sessions, limited duration, so it is going to be tough. And again, I will note that exposure might not be appropriate for all of your patients. You really have to use your clinical judgment, taking into account, the person's motivation, their distress tolerance skills, their symptom severity, things like that, to figure out if even going there at all makes sense for them. But a lot of times you can touch on exposure, and the main way to do that is highlighted in red here. So in PCBH, sometimes our biggest intervention related to exposure is just providing education about the role of avoidance in maintaining anxiety. So you can use an example from their own life of stuff that they stopped doing as a coping strategy, to avoid anxiety. You can use a diagram like this vicious cycle diagram here, but just explaining to them how avoidance is what maintains anxiety. That simple information can go a long way for a lot of people. If you want to go even farther, you can just work on developing a plan for how they would endure certain situations rather than avoid them. So, you're socially anxious, so you stopped going to your daughter's soccer games. How can we, can we get you to just go to the game? Can you go to the first quarter of the game? And then, you can leave something as simple as that. You're working on exposure at the end of the day, although it seems kind of camouflaged. And people's willingness to tolerate distress is higher for things that are really important to them. So if possible, when you're working on the exposure, if you can tie in the values, that will make them more likely to actually comply. So, this kind of basic, less complicated version of exposure can be good if the patient's symptoms are mild or moderate. If it's a really bad situation, very severe symptoms, your goal might just be to target motivation for them to take a referral to specialty care. You're probably not going to, get into exposure with them, but you're going to work on getting them connected to the level of care that they need. And that's another worthwhile intervention, is making that referral. If you do feel that you can do some more traditional exposure work in PCBH and it's appropriate for the patient, they're stable enough, they're motivated, they have coping skills, whatever, Then you could approach your standard anxiety hierarchy like we have been taught in specialty care. You can help them do the hierarchy in session or get started on it, explain it in one session. They can complete it for homework. Second session, you might do, you could do one of the exposures in session, you know, if you have 30 minutes. And then help them plan exposures that they could do for homework. So again, this is going to be rare probably that you would actually do this in PCBH, but it can be done, and I've seen it done well. If you do exposures, of course, make sure you're doing the first one at least in session, so you're there with them and have a way for the patient to check in with you between sessions in case there's any concerns. But this is how, you know, you can adapt exposure to fit PCBH. And again, I want to highlight really just education about exposure and anxiety, and encouraging them not to avoid certain things is really a great intervention, and that might be all you do, and that's perfectly fine. Here are some resources, some hierarchy type handouts and stuff like that that you might use with patients if you're going this route. All right, and finally I wanted to talk about behavioral activation, which is a empirically supported treatment for depression. But I talk about it because it's important given the high comorbidity between anxiety and depression. So we know that at least half, if not more, of our patients with anxiety are also having depressive symptoms. So this can be good to use with your patients. And preliminary research suggests that behavioral activation can also reduce anxiety symptoms, so people are starting to look at that also. And in general, behavioral activation operates by decreasing avoidance, so that is a nice approach for our patients with anxiety, because that's what we're trying to do with them as well. So BA uses assessment of values and then activity scheduling to help people re-engage with life. And it's important when you're doing BA, you're not just trying to figure out pleasurable events. That's kind of been the traditional message that we get, but you really, to have this be as impactful as it can, you want to have valued activities that are consistent with the patient's values to get the biggest bang for your buck. Okay, so how would you do this? I would first just briefly do quick education about the depression spiral and how people start withdrawing from life as they get depressed, and that helps set up the rationale for this approach. And then you would work with the patient to identify some pleasurable valued activities. So you can just use straightforward verbal questioning, you know, about hobbies you used to enjoy, or how would you spend your time if you weren't feeling so down, something like that. Some people can name some things right there. What's important to you, you know. Some people will need a questionnaire or a list or a worksheet. I'll give you a bunch of different options for that. Once you've identified the patient's values, then you work with them to set some specific goals. So you want to help them come up with a very simple, small number of goals to start with, like 1 to 3 at the most. You want to make SMART goals and have them be tied to their values. And you want to pick things that can be easily achieved in the next 2 weeks. You don't want to have major barriers in terms of time, money, effort, other people, whatever. You need to pick something they can actually do because you want to build self-efficacy and have this work for them. But you really want to get specific in what they do. So, you know, if they say, oh, I guess I could meet up with a friend or meet up with someone. You want to turn that into meet my sister for coffee on Saturday afternoon, so that it's very specific, because that makes it more likely that they'll actually do it if you nail down the details and get it scheduled. Okay, for values assessment, I wanted to note there's a lot of good resources out there that can help you. And again, the values tools are useful if you're working on an acceptance-based approach, or even if you're coming up with targets for exposure or whatever. Values assessment is important. Great handouts on that. So I just wanted to show you that. And then I have a link here to a chapter on behavioral activation in the CBT manual, as well as a lot of patient handouts that you can use. So check those out. Okay, so I did want to, of course, acknowledge that the 6 things I just talked about are not the only approaches that you can use in PCBH. There's a lot of other things that have good evidence behind them and are very compatible with brief sessions. So your problem-solving therapy, solution-focused therapy, self-help, those are all great options if that's what you want to do. Focused acceptance and commitment therapy is becoming more popular as well, and I think there's going to be a webinar on that coming up later this year. That's another approach that a lot of people like. So just wanted to acknowledge that there are other options, and some people are going to be more open to lifestyle changes than they are to things that sound like mental health treatment. So some people might respond better to the idea of exercise or working on their sleep or something if that's what they want to focus on, support them. Okay, and then what kinds of things do you need to think about when you're trying to figure out which of these makes the most sense? So I would urge you to consider patient factors like the ones listed here, as well as yourself and provider factors, and use your clinical judgment to determine what's the most appropriate for the patient. So you want to think about, for example, what is the presentation of these anxiety symptoms? Some people it's more somatic, some people it's more cognitive. If it's more somatic, probably don't pick cognitive therapy. If it's more cognitive, probably don't pick relaxation training. Pick something that matches what they need. Also consider what may have helped them in the past or what piques their interest and gets them, excited and seems to get their buy-in. And of course, you want to think about their thinking style, their level of psychological mindedness, things like that. And then on your end, you need to think about your confidence to apply these skills and your comfort doing it. And hopefully an overview of this helps you see how these different things are possible. And I've given you a lot of resources, so hope that will make people feel more comfortable using the different options. And regardless of what specific technique or approach you use, of course, we want to deliver compassionate, patient-centered care and give the best care to our patients. I wanted to make a quick plug for measurement-based care. No matter what approach you're using, what interventions you're using, I encourage you to use brief self-report measures so that you can track how patients are doing and get some data that is more objective versus just their subjective self-report, though I'm doing a little bit better. So I list some measures that you might use here. And then I wanted to wrap up with some key points. So there's really not a lot out there in terms of manualized interventions or specific interventions that research has been done on that really fit the PCBH model. So right now, the best we can do is adapt existing evidence-based interventions to fit what we're doing. And the key takeaway is just keeping in mind the different goals and the different population that we're seeing in PCBH compared to specialty mental health. It's not the same. It's not the same population. It's not the same goals. So you have to adjust the focus and the scope of what you're doing accordingly. So again, more psychoeducation and more self-management skills, because that's what is emphasized in primary care. And we only have, we have a 25-minute appointment, so 10 to 15 minutes I'm doing functional assessment, trying to figure out what is the presenting complaint. And then I have 10 minutes left to do something. So I need, a 5-minute behavioral demonstration of some technique, and then they practice at home. We don't have time to get into, cognitive restructuring in a formal way like we would in specialty care, so we have to adjust it down. And then, adjust your expectations and the scope of the intervention. So you're not trying to treat somebody to remission in this model. You're trying to give them a little symptom relief so that they can get back on track and function better in their life. So maybe they just need one key piece of information or one good coping skill that's going to help them get some relief, and that would be successful, and that would be great for them. So keep that in mind when you're thinking about what you're doing. Okay, I wanted to point out an article that my colleagues and I just published in Family Systems and Health. It has a lot of the same topics that we talked about today, so that might be helpful for people. I have my email here. If you have any questions for me later, I'm happy to be in touch. And then I also have the website for the Center for Integrated Care. which is a VA Research Center of Excellence on Integrated Primary Care. And we have a host, and I'm talking a host of resources for patients and clinicians about integrated care. There's all kinds of goodies on there, so I encourage you to check that out. And let's see what else. Oh, here's some key resources of articles that I think are great. And then I put all of my references in case any questions about anything in the slides. And I believe there's an evaluation form coming to you. And that concludes my talk. And now I'm happy to take any questions.
Thank you, Dr. Shepherdson. As Robin said, please feel free to ask questions. We've got probably 5 or 6 minutes left in the webinar today. Just as a reminder, this webinar has been recorded and will be on the CFHA website, which is www.cfha.net. And if you search for webinar archives, all of our past webinars are archived there, and the PowerPoint slide for today's presentation will also be there. So please feel free to check that out. I'm not seeing at this point, Dr. Shepherdson, any questions. We'll give it just a minute or two more.
Well, if anyone thinks of anything later, of course, please feel free to email me. Happy to answer anything if it comes up.
Perfect. Perfect. Thank you so much, Dr. Shepherdson, for your time today. As a reminder, we have a monthly webinar each month. Next month will be sponsored by the Families in Health Special Interest Group, and I believe it will be June 14th with Dr. Barry Jacobs. More information to come on that, and we'd like to thank you all for joining us today. Have a wonderful afternoon.